Here from the Framingham study published just 2 years ago, we had a follow-up here of better than 5 years, and 120 individuals in the cohort developed a major cardiovascular event. And what that meant was cardiac death or myocardial infarction or congestive failure. And the hazard ratio of having one of these events was compared relative to the then lower end of the laboratory reference range, 15 nanograms per milliliter. If you were below that, what was your risk? And here's what the hazard ratio shows on your right-hand side. With those above 15 being giving, as usual, the reference value of 1.0, and those falling below had a 53% increase in risk of one of these major cardiovascular events. And those that were even lower, that is below 10, had an 80% increase in risk. So once again, here's another body system showing impressive effects. Let's move to influenza. This is a study from Japanese school children aged 6 to 15, average weight about 35 kilos. They were given 1,200 international units per day in addition to whatever self-supplementation their parents had assigned to them. And here's what we see in terms of relative risk. We have 3 groups here, a placebo group who didn't get any vitamin D. Here's a group that got vitamin D, and some of whom had been getting vitamin D previously from their parents. And here's a group that had not, and so they were getting vitamin D only from the study. And you see a 70% reduction in influenza, serologically proved influenza during the winter of 2008-2009 in this group of 334 Japanese school children. So one more example of yet another body system. We see this same kind of an effect in our own NHANES data, one of the questions of which asked the participants whether they'd had a recent upper respiratory tract infection, cold, flu, the crud, whatever you wanted to call it under the circumstances. And what they did simply is look at the percent with a recent urinary or, upper respiratory tract infection as a function of the serum 25-hydroxy-D level here, under 10, 10 to 30, and above 30, 30 being, of course, the lower end of what we might have considered an acceptable range. And once again, you see the same downward trend. The worse your vitamin D status, the higher the chances are that you've had a recent upper respiratory tract infection. 29% reduction there, highly statistically significant. Now, it's also of considerable interest that the association was much stronger for those with asthma and chronic obstructive pulmonary disease, one of the problems that we have to wrestle with in this day and age as well. Here perhaps is one of the more dramatic effects published 4 years ago. It's another double-blind, placebo-controlled, randomized trial, 67 patients with advanced pulmonary tuberculosis, all of whom received the standard anti-tubercular therapy. And the investigators, of course, used what's called sputum conversion. That is, could you find the tuberculosis bacteria in the sputum after you've treated? And if you couldn't find it anymore, then you consider that effectively a cure. And so they used that as the measure. Now, the placebo group had a 76% sputum conversion rate, which I'm told by my infectious disease colleagues is about par for the course. Those who got the vitamin D in addition to standard anti-tubercular therapy had no treatment failures. Every single one had sputum conversion. Now, recall this is a double-blind placebo-controlled trial. There's no way to fudge these data just because you wanted it to come out in a particular way. Now, by no means does this mean that vitamin D deficiency causes tuberculosis. This is simply an instance of the point I made earlier on, that the body is trying to repair these problems, and if it has inadequate vitamin D, it can't do it very well. There used to be a saying out of Atlanta that things go better with Coke. And I think what we know today is that all medical treatments go better with vitamin D. Not because the vitamin D treats the disease, but because the vitamin D treats the the body, and the body does a better job then of responding to the medical treatment that we have available. We've already spent a moment on breast cancer risk, and so I'm going to go rapidly through this, but I mean, I could use the same bar graph for virtually all of these diseases. They all show the same pattern. The higher the vitamin D status, the lower the risk of having one of these problems. In this case, this study showed a 69% decrease in risk. Colorectal cancer, exactly the same kind of a phenomenon. This is from the Nurses' Health Study. We see this downward trend that is statistically significant as a function of improving vitamin D quintiles. Here's the study that Joan Lappy from our unit at Creighton published a couple of years ago, looking at all the major cancers afflicting postmenopausal women in the Fremont study. These are our survival curves with the calcium and vitamin D treatment arm up at the top and the placebo arm at the bottom, with 3 times the risk of having incident cancer over the 4 years of the trial if you were in the placebo group, as contrasted with being in the calcium plus D group. Now, in the remaining couple of moments, I want to go back and review for you some of what we've learned in rethinking cell biology. When I went to school and learned about cells, we knew they all had a nucleus, and the nucleus has all the genetic material you need to make a new cell or a new organism, for that matter. That's the basis for cloning. But we weren't quite clear why it was so important, except that if you're a skin cell, you've got to make copies of yourself because the skin keeps shedding and you have to make new cells. Or if you have a cut, you have to heal the wound. So that made sense. But we now understand that the DNA is in there because we are constantly accessing the information it contains in order to make needed cellular apparatus. Secondly, we understood that cells differed from one another. You have muscle cells and skin cells and intestinal cells and heart cells and so forth. And we pretty much thought that differentiation was a function of what was in the cytoplasm, that is, the part of the cell outside of the nucleus. But we now understand that the real basis for that differentiation is not so much what's in the cytoplasm, but which genes can be accessed in that particular cell. And a muscle cell can access the genes that are important for muscle function, and a skin cell can access the genes that are important for skin function, and a white blood cell can access the genes that are important for white blood cell function. Now, that leads us then to kind of make, in a general cartoon way, a scheme for how a cell responds to any kind of a signal, normal or abnormal. Here's a kind of a schematic cell that's responding to a signal in the form of a bacterium that's trying to invade it. And what happens is that the cell says to itself, goodness, I don't have the equipment I need to deal with this. But then it scratches its head and says, but I do have the plans for what I need in my DNA library. And so it goes into that DNA library, taking the bacterium with it, and it synthesizes the cellular equipment it needs to deal with that particular bacterium. And that constitutes the cell's response. So this is how all of our cells are functioning all of the time. 1,25-dihydroxyvitamin D, the so-called active form of vitamin D, is the key that unlocks the DNA library in most of our cells. But it's not just any 125D. It's 125D that's synthesized in the cell itself, by itself, for itself. That's the one that unlocks the DNA library. We have some of this compound, 125D, called calcitriol, circulating in our blood. But that's not the one that's operative in the tissues. The tissues make their own individually. Now, how much is enough? Well, we've seen in Carroll's diagram, 10 nanograms per milliliter will pretty much deal with rickets. 20% will get rid of, 20 nanograms will get rid of 98% of it. Calcium absorption is optimized at about 32 nanograms. Various pregnancy outcomes require probably close to 50 nanograms per milliliter. Cancer outcomes in our hands, but that's just the ones that we've been able to study at Creighton. 40 nanograms, probably closer to 50 to 60, maybe if Cedric Garland's right, as high as 80 perhaps, I don't know. And we don't have good numbers for many of the other disease endpoints, multiple sclerosis, diabetes, etc. So this is a question of stay tuned because we don't know where these are going to come out. In terms of managing our own vitamin D status, or as patients managing that of our, as physicians managing that of our patients, an input requirement in the range of 75 international units per kilo per day will pretty much take care of at least the minimal requirements of everybody. It's a lot more than current recommendations, probably a lot more than is going to be recommended next Tuesday when the Institute of Medicine releases its current round of recommendations. Most adults will need, in addition to whatever they're getting from any other input, they'll need 1,000 to 3,000 international units per day above what they're already getting. The response in serum 25-hydroxy-D varies widely. Carol showed you that. Yeah, but it's the serum 25D concentration that has to be optimized. It's not the oral dose. And the right oral dose is the one that produces and maintains the right 25D level. It's going to be different from person to person. That's why Carol told you she couldn't tell you how much you needed. I want to close on an issue of safety because we've both been talking about higher numbers than people used to think were okay. This is a batch of data that were assembled for a paper published 3 years ago on the evaluation of vitamin D safety and toxicity. The blue circles are the means of studies of controlled dosing over finite time periods, with the highest dose being 50,000 international units per day for a period of about 12 weeks. The triangles are from cases of vitamin D intoxication published in the literature. And for both cases, we're dealing with situations where the vitamin D intake was known and the serum 25-hydroxy-D was measured. Now, you can see without too much difficulty that these data are following a curve that would look like this. And that curve turns out to be very reproducible. But the point I want to make here for safety purposes is that there's been no report of toxicity below 500 nanomoles or 200 nanograms per milliliter. And there's been no case reported with daily doses less than 30,000 international units per day. Now, nobody's recommending 30,000 international units. It's not necessary to achieve the endpoints we're talking about, but it's nice to know that you've got that kind of a margin of safety. And so to wrap this up and to leave a couple moments for questions, we want to stress, as I think all three speakers have done, that serum 25D levels below 30, 32 are not adequate for any body system with the exception of rickets. Levels as high as 50 nanograms may be closer to optimal. Inputs from all sources combined, that is those needed to sustain 32 nanograms, are in the range of 4,000 international units per day and higher. Some of that may be coming from the sun. You may be getting that already, sun and food. This is total need in order to sustain that kind of a level. And with that, I thank you.
Thank you very much, Dr. Haney. We have some time to ask a few questions. Anyone have any questions, please raise your hands up.
I'd like to ask Dr. Haney, the brands at like Costco or Walmart, is there a difference between the vitamin Ds over the counter